This pansystolic murmur is classic for mitral regurgitation. One feature that distinguishes regurgitant murmurs from ejection ones is that they tend to go all the way to the second heart sound. Listen once again to mitral regurgitation. A third heart sound may occur with mitral regurgitation and can be a sign of a large regurgitant volume or left ventricular dysfunction. I will start with normal heart sounds and then add the third heart sound and then the murmur. When mitral regurgitation is due to mitral valve prolapse, the murmur may be crescendo in character, beginning in mid-systole and increasing to the second heart sound. The murmur of mitral valve prolapse decreases with squatting. Listen to the change of this murmur with a squat maneuver. Standing. Squatting. Another variant of mitral regurgitation is the decrescendo murmur of acute mitral regurgitation. As the pressures in the left atrium and ventricle equalize towards the end of systole, the intensity of this murmur decreases. A common cause of mitral regurgitation is myxomatous degeneration of the mitral valve, as shown here. This disease can result in rupture of a chordae tendineae with acute mitral regurgitation. With the rupture of a chordae tendineae, there may be a third heart sound and a fourth heart sound, as well as a murmur. I will begin with normal heart sounds and then add the third sound, then the fourth, and finally the murmur. Patients with acute mitral regurgitation can present with severe heart failure and may need stabilization with intra-aortic balloon counterpulsation prior to emergent surgery. Recently, percutaneous mitral valve repair has become available for patients with suitable anatomy. Listen once again to a patient with both a third and a fourth heart sound and mitral regurgitation. In summary, mitral regurgitation may have different shapes depending on its etiology. On occasion, a third and a fourth heart sound may accompany mitral regurgitation. This high-pitched, blowing, diastolic murmur, heard along the left sternal border, is typical of aortic regurgitation. Notice the decrescendo nature of this murmur. This murmur gets louder with an increase in afterload. Notice the change in this murmur with a hand grip maneuver. Rest. Hand grip. This murmur has a pitch similar to respiratory sounds and can be overlooked unless the clinician listens to the patient in held expiration. Notice how much easier it is to hear this murmur with held expiration. Breathing. Held expiration. Rupture of an aortic cusp can result in a cooing dove murmur. This type of murmur has a unique auditory signature. In severe aortic regurgitation, there may be early mitral valve closure, resulting in an Austin Flint murmur. Although similar to mitral stenosis, this murmur is introduced by a third heart sound, and the first heart sound may be normal or even diminished. Listen to an Austin Flint murmur. I will begin with normal sounds, then add the third sound, and finally the Austin Flint murmur. A systolic murmur is common in patients with moderate to severe aortic regurgitation. This murmur results from the large stroke volume ejected across the deformed aortic valve during systole. This murmur typically peaks in the first half of systole in the absence of significant aortic stenosis. I will begin with the diastolic murmur and then add the ejection murmur. In patients with both aortic stenosis and regurgitation, the systolic murmur usually peaks later in systole. I will begin with the systolic murmur of aortic stenosis and then add the diastolic murmur. If aortic regurgitation is heard to the right of the sternum, then aortic root pathology, such as an aortic aneurysm, should be suspected. Just before heart failure develops, patients with significant aortic regurgitation should have their valve replaced. Many cardiologists follow the 55 rule, recommending valve replacement when the left ventricular end systolic diameter reaches 55 millimeters or left ventricular ejection fraction falls below 55%. Aortic dissection can result in acute severe aortic regurgitation. In this situation, there is decreased forward stroke volume, resulting in pulmonary edema and sometimes cardiogenic shock. The arterial tree clamps down and prevents the wide pulse pressure normally seen in chronic aortic regurgitation. The absence of this common sign can make it challenging to diagnose acute severe aortic regurgitation. In summary, aortic regurgitation typically presents with a diastolic decrescendo murmur, which is heard along the left sternal border. Acute aortic regurgitation can occur as a result of trauma, endocarditis, or aortic dissection. Listen once again to the sound of severe aortic regurgitation. This diastolic rumbling murmur is typical for mitral stenosis. Notice the increased S1 and loud opening snap that accompany this murmur. In mitral stenosis, the A2 to opening snap interval is related to the severity of obstruction. Patients with severe mitral stenosis often have an A2 to opening snap interval of 80 milliseconds or less. The murmur of mitral stenosis is low-pitched and requires the bell of the stethoscope to be held lightly on the chest wall. Newer electronic stethoscopes make this murmur easier to hear. The murmur of mitral stenosis becomes louder with maneuvers that increase heart rate. An easy way to produce this effect at the bedside is to have the patient perform a few sit-ups. Note the change in this murmur as the heart rate increases. At heart rates above 85 beats per minute, systole and diastole may become equal in duration, and a diastolic murmur like mitral stenosis can be mistaken for a systolic one. Listen to the murmur of mitral stenosis at a heart rate of 85 and notice how easy it is to mistake this for a systolic murmur. I will begin with normal heart sounds and then add the opening snap and then the murmur. Mitral stenosis and mitral regurgitation sometimes occur together, and it can be challenging to detect the diastolic murmur in this setting. Listen to the combined murmurs of mitral stenosis and mitral regurgitation. I will start with S1 and S2, add the opening snap, then the murmur of mitral stenosis, and finally the murmur of mitral regurgitation. With the advent of three-dimensional echocardiography, new details on mitral valve pathology are becoming available. This image shows mitral stenosis from the view of the left atrium. Percutaneous balloon valvuloplasty is an effective treatment for patients with mitral stenosis who have appropriate findings. These findings include commissural fusion of non-calcified pliable leaflets with no atrial thrombus nor significant mitral regurgitation. Listen once again to combine mitral stenosis and regurgitation. In calcific mitral stenosis, both the opening snap and loud first heart sound can be lost due to leaflet immobility, but the murmur remains. Echo Doppler cardiography remains the best diagnostic test to detect and quantify mitral stenosis. In summary, mitral stenosis, although decreasing in developed countries, remains a continuing challenge in much of the world. Diagnostic and therapeutic advances for patients with this disease have led to successful interventions by cardiologists. Listen once again to combine mitral stenosis and regurgitation. This systolic ejection murmur reflects turbulent flow across the stenotic aortic valve. In contrast to an innocent murmur, this murmur peaks late in systole. Notice the late peaking of this murmur. Innocent murmurs reflect a normal flow velocity profile across the aortic valve. Aortic stenosis, on the other hand, has a delayed peak, reflecting the increased obstruction to outflow. Notice how the innocent murmur peaks early in systole and compare that to the late peaking of aortic stenosis. First, the innocent murmur. And now aortic stenosis. The presence of an ejection click localizes the obstruction to the valvular level and strongly suggests the presence of a bicuspid aortic valve. I will begin with normal heart sounds and then add the ejection click and then the murmur of aortic stenosis. Pathologic murmurs secondary to obstruction across the left ventricular outflow tract can occur at the subvalvular, valvular, or even supravalvular level. Notice the ejection click that initiates this murmur. With significant aortic stenosis, the carotid upstroke may be both delayed and diminished. The murmur of aortic stenosis will, on occasion, be audible at the cardiac apex with a change in pitch, the Galivar-Dan phenomenon. Despite this increase in pitch, this murmur retains its characteristic diamond shape. Listen to this murmur first at the second right intercostal space, and now at the apex. Although stress testing is contraindicated in symptomatic patients with aortic stenosis, it has been safely performed in asymptomatic patients. As many as 1/3 of asymptomatic patients will demonstrate symptoms or abnormalities on exercise testing that may warrant valve replacement. Listen to a patient with combined aortic stenosis and regurgitation. I will begin with the systolic murmur and then add the diastolic component. Patients with aortic stenosis and a low ejection fraction are problematic. One way to identify those patients who will respond well to surgery is pharmacologic stress testing. If their gradient increases significantly with dalbutamine infusion, then these patients are acceptable candidates for surgery. Listen to a patient with aortic stenosis and both a third and a fourth heart sound. I will begin with the fourth heart sound, then add the third sound, and finally the murmur. Recently, percutaneous aortic valve replacement has been introduced. Clinical trials, still in progress, will reveal the indications and benefits of this exciting new approach to aortic valve replacement. Echo Doppler studies can define valve anatomy and function, allowing a calculation of both valve gradient as well as valve area. In summary, aortic stenosis usually presents with a late peaking, diamond-shaped murmur heard best at the second right intercostal space. When this murmur is accompanied by an ejection click, it suggests a bicuspid aortic valve. Listen once again to the murmur of combined aortic stenosis and regurgitation. This systolic ejection murmur, heard at the third left intercostal space, is the right ventricular outflow murmur of tetralogy of Fallot. The large ventricular septal defect, shown here, does not produce a murmur because the pressures are equal in both ventricles. Listen once again to the murmur of tetralogy of Fallot. Tetralogy of Fallot consists of 4 components: subpulmonic stenosis, ventricular septal defect, an overriding aorta, and right ventricular hypertrophy. This disease is the most common cause of cyanotic heart disease after infancy. What is unusual about this ejection murmur is that its intensity and duration are inversely related to the amount of obstruction across the pulmonic outflow tract. As the obstruction increases, the murmur becomes shorter, softer, and peaks earlier in systole, reflecting decreased pulmonary flow, while the large ventricular septal defect allows more shunting of blood to the left ventricle. Over the last 3 decades, advances in surgical treatment have dramatically improved the survival of patients with tetralogy of Fallot. In fact, survival to age 30 has increased from 6% to 86% for those with successful operative repair. A repair of tetralogy of Fallot includes a patch closure of the ventricular septal defect, resection of subpulmonic obstruction, and placement of a transannular patch across the pulmonary valve. For many patients, this transannular patch results in pulmonic regurgitation. In addition, many patients will have both a systolic murmur of residual stenosis as well as the diastolic murmur of regurgitation. Listen to the combined murmurs of pulmonic stenosis and regurgitation. I will start with the systolic murmur and then add the diastolic murmur. Following surgical repair, some patients may have a pansystolic murmur at the lower left sternal border due to a residual septal defect around the patch. Listen to the sound of a small residual ventricular septal defect. Patients with repaired tetralogy of Fallot are at risk for sudden death, which accounts for 70% of late deaths. Several studies have shown that when the QRS approaches 180 milliseconds, patients have an increased risk of ventricular tachycardia. Listen once again to combined pulmonic stenosis and regurgitation. In following adult patients with repaired tetralogy of Fallot, it is recommended that they have yearly examinations, including electrocardiograms, echocardiograms, and Holter monitoring. In summary, survival following repair of tetralogy of Fallot has improved dramatically in the last 3 decades. However, even after successful repair, patients are at risk of late sudden death when their QRS approaches 180 milliseconds. Listen once again to the murmurs of pulmonic stenosis and regurgitation. A continuous murmur, which peaks around the second heart sound and declines in diastole, is typical of patent ductus arteriosus. Listen to a patient with patent ductus. I will start with 3 normal beats and then add the murmur. Patent ductus arteriosus is usually loudest at the second left intercostal space. This murmur is due to flow from the aorta through the ductus and into the pulmonary artery throughout the cardiac cycle. Two-dimensional Doppler echocardiography may demonstrate continuous flow into the pulmonary artery. The continuous murmur of a patent ductus arteriosus peaks around the second heart sound and continues through this sound into diastole. The first surgical closure of a patent ductus was performed in 1938 by Dr. Robert Gross, when he was a 32-year-old chief surgical resident. This landmark operation launched the modern era of cardiac surgery. A patent ductus arteriosus can also be visualized by a CT scan of the chest. In some patients, a patent ductus can now be closed percutaneously with a thrombogenic coil inserted in the ductus. In summary, patent ductus arteriosus results in a continuous murmur heard at the second left intercostal space. In 1938, this was the first cardiac lesion to be successfully repaired. Listen once again to a patent ductus arteriosus. Review session. I will now play each of the sounds you have just learned and pause to give you time to identify the sound. I will then give the name of the sound. Recorded at the apex. Mitral stenosis and mitral regurgitation. Recorded at the second right intercostal space. Aortic stenosis and aortic regurgitation. Recorded at the apex. Acute mitral regurgitation. Recorded at the fourth left intercostal space. Aortic regurgitation and a systolic flow murmur. recorded at the second left intercostal space.
Pulmonic stenosis and pulmonic regurgitation.
Recorded at the second left intercostal space.
Patent ductus arteriosus.
If you did not recognize each of these murmurs, you may want to listen to that segment of the program again. I hope you have found this program to be both enjoyable and useful in your care of patients.